cervical discogenic pain is a real entity. It has anatomical and physiological bases and foundations. Is there a pointer here? Did someone take the pointer to their desk, George? Thank you. It's there. So when we talk about etiology and risk factors, diagnostic criteria, therapeutic options for cervical discogenic pain, and controversies, as well as unresolved issues. I am Dr. Candido. I do practice in Chicago. I'm a professor of both clinical surgery as well as clinical anesthesiology at the University of Illinois College of Medicine. Presently, I am in a private practice scenario. I used to be a fellowship director for two major programs in the Chicagoland area. If you look at this anatomy, we had a talk this morning as the first talk, as you know, about cervicogenic headache, and we talked about the facet joints. We talked about the zygapophyseal joints. We talked extensively about the atlanto-occipital and the atlanto-axial joints and the implications of the joints, the ligaments, and other structures in providing headache pain, sometimes neck pain, upper extremity pain, unilaterally, of course. Now we're focusing on the intervertebral discs. So where you see the little green star right here is the subject of our discussion right now today. And of course, everybody in this room goes through Thompson's criteria. As you're sitting here, each and every one of you is losing cells at a finite rate. You're losing water from the intervertebral disc. We're getting dehydrated and desiccated discs. If we took an MRI scan of every single person in this room, 80% of you at least would have changes of spondylosis. And you're obviously, most of you are sitting comfortably. Nobody is screaming about their necks or their lower backs, but you're going through at an accelerated rate Thompson's criteria. You're losing cells, you're reducing your type 2 collagen and changing and increasing type 1 collagen. You're getting radial annular fissures as you sit here. You're getting mechanical incompetence, you're getting bony changes. Why are you not in pain? Because the anatomy is not the number one factor implicating whether or not you have pain. Unless, of course, you have mechanical compression. In 1934, Mixter and Barr, two surgeons up in New England, wrote a paper in the New England Surgical Society Journal suggesting that discogenic pain was related to mechanical incompetence with compression of nerves. We know that that's not the fundamental reason for why individuals have discogenic pain, is it? And it's due to the nerve innervation back in 1934, so 111 years ago almost. They didn't understand, 91 years ago, they didn't understand conceptually the fact that there was an innervation to the disc. On the lateral aspect, we have the gray rami communicantes. We have in the inner portion of the disc, the ventral ramus, and of course everyone is familiar with the sinuvertebral nerve at the posterior part of the annulus. It's been implicated in pain, but not all pain emanates from the sinuvertebral nerve. This is a transverse axial section showing where the innervation is of the disc. This is a lumbar disc, of course, but this situation is analogous in the cervical spine. We have sinuvertebral nerve in the cervical spine. We have ventral ramus and we have gray rami communicantes. So fascinating to me was that even past 1934, 1944, 50s, 60s, 70s, it wasn't until the 80s that we realized that these nerves had chemicals that mediate nociception. And these chemicals that mediate nociception are about 7. They include calcitonin gene-related peptide. They include vasoactive intestinal peptide, phospholipase A2, histamine, lactic acid, bradykinin, and phospholipase A2. So phospholipase A2 was very interesting because it was implicated by the Saul brothers, S-A-U-L, two brothers, physiatrists practicing in San Francisco, California, that isolated phospholipase A2 and found that there was a very high concentration of phospholipase A2 in discs that were bulging, in discs that were damaged and injured, and they implicated phospholipase A2 as the reason for why discogenic pain was prevalent in certain individuals. Now, all of these chemicals are fundamentally characteristic of nociception. However, it's phospholipase A2 that we have the greatest respect for because things that we inject in our patients, like steroids, like platelet-rich plasma, like human mesenchymal stem cells, whether they're derived from bone marrow, aspirate, or adipose tissue, or even umbilical cords and from the placenta, human placenta, they are implicated in shutting down the metabolic pathways associated with inflammation. This is a schematic. Obviously, we don't treat anatomy, right? We have individuals who may have discogenic changes on a two-dimensional representation of a three-dimensional person. There are people in this audience right now who have 2 millimeter, 3 millimeter, 5 millimeter disc protrusions who are not complaining of pain. Why? Because again, they're not liberating chemical inflammatory mediators at this very time. Every one of us, myself included. The MRI of my lumbar spine, the MRI of my cervical spine looks like a 90-year-old person from multiple years of overexertion and sports injuries, yet I'm completely asymptomatic. So we don't treat pictures, do we? We treat individuals based upon our comprehensive neurological and physiological and musculoskeletal assessment before we treat them. I find this fascinating. We have maps. These are anatomical maps, which we owe a great deal of gratitude to Nikolai Bogduk, Charles April, Leslie, Lord, Barnsley, others, who created these maps of stimulation of the intervertebral disc and stimulation of the zygapophyseal joints. In the neck, you can see the overlap of the zygapophyseal joint map for pain is almost identical to the map which is created by disc stimulation. How can that be? How can the discs and the joints, the facet joints, give rise to exactly the same pain patterns? And that's the conundrum when we're trying to find out whether or not somebody has discogenic pain, facet joint related pain, musculoskeletal pain, or none of the above. And this is the original article from almost 18 years ago from Bob, April, and others, Cooper and Bailey, which shows how that map was created. They actually stuck needles into the joints, they stimulated these joints electronically, and then they, on a series of patients, they drew this map. They did a similar study in the intervertebral disc. This is one of their really important papers. This paper is actually quite old. It's now 32 years old. And what they took was a series of patients who had sustained motor vehicle accidents. There were 56 patients. These 56 patients all had neck pain. And Bogduk and April said, well, where is this neck pain coming from? Is it coming from the facet joints? Is it coming from the intervertebral disc? Is it coming from both the discs and the facet joints? Or is it coming from neither the discs or the facet joints? So how could they determine where this neck pain was coming from? Well, obviously they did a targeted series of facet joint injections, and they waited to see what the patient's response was. Then they did intervertebral injections, disc injections, and they saw whether or not they could replicate the patient's pain. And then they said, some of these patients are going to have pain just from the facet joints, some of these patients are going to have pain just from the discs, and some of these patients are going to have pain from neither the facet joint or the disc, and some are going to have pain from both the facet joint and the disc. And this is what they found. This is a classic paper, one of the most important papers in interventional pain. 20% of the patients who had neck pain and headache had only disc-related pain. 20% of the patients who had headache and neck pain had only facet joint-related pain. 40%, or 2 out of 5 of the patients, had pain that came from both the facet joints as well as the intervertebral disc. And 20%, or 1/5 of patients, had neither pain from the facet joints or the discs. So where was their pain coming from? Well, it was musculoskeletal. So this is what you're going to find in a large pain consortium or pain practice where you're treating a lot of individuals who've had not just traumatic-induced pain, but any kind of headache and neck pain. Anybody know who this individual is? Ralph Cloward. Ralph Cloward was a neurosurgeon from the United States of America. He was born in 1908, he died in the year 2000. And he did his training, his medical training at Rush University Medical Center in Chicago. And in 1938, he went out to Honolulu, Hawaii, and he was the only neurosurgeon in Hawaii for many, many years. When the Japanese bombed Pearl Harbor in 1941, Cloward was the only neurosurgeon on the island. He did, by himself, 44 craniotomy procedures in a 3.5-day period. He did not sleep for almost 96 hours. He did 44 craniotomies. But we're not here to talk about craniotomies. We're here to talk about spine. Cloward was the first surgeon in the world to perform a posterior lumbar interbody fusion. He did that in the 1940s. In 1958, Cloward was the first neurosurgeon in the world to perform an anterior cervical discectomy and fusion. So any of the neurosurgeons in this room, I know there are some, you owe a debt of gratitude to Ralph Cloward, who created many of the pathways of what you do today. But why are we talking? Why am I talking about Cloward? I'm not a neurosurgeon. I'm talking about him because he found that the gray Raymond communicantes, when stimulated, would give not headache pain, not neck pain, but interscapular pain. So why is this important? Because the discs can give rise to interscapular pain. We've had many, many great discussions today about myofascial conditions and the things which can be considered painful between the fascia. Dr. Lamb gave us fantastic anatomical dissections of the fascia, and that may be part of the problem, but never underestimate the fact that the intervertebral discs of the cervical spine can give posterior back pain and interscapular pain, and that was determined by Cloward back in 1956. So what is the etiology? What is the diagnosis of cervicogenic pain? Again, in the early parts of the last century, 1934, Mixler and Barr told us that pain came from mechanical compression of the nerves. In fact, they misidentified a herniated disc as a chondroma. A chondroma is a tumor of cartilage. So they thought that when a patient on anatomical dissection had a herniated disc, what they were really seeing was a tumorous structure that was created. In fact, it was totally misdirected and misidentified. But we also know over the decades and over the years that there are inflammatory changes that occur. The nerves that we already discussed can be nociceptive, and they are nociceptive because of the process of degeneration, which leads to inflammation. So what are the chemicals that we talked about? We talked about histamine, lactic acid, bradykinin, substance P. We talked about calcitonin, gene-related peptide, vasoactive intestinal peptide, and phospholipase A2. But what about things like nerve growth factor? So this is a beautiful paper. It talks about the fact that with cervical disc degeneration and spondylosis, we have an upregulation of nerve growth factor, an increase in nerve growth factor DNA, and we also have an upregulation of substance P. These are the chemicals which are, in fact, responsible for why individuals develop cervicogenic pain related to disc degeneration, so discogenic pain. A more recent publication last year in 2024 that looked at 111 cervical disc samples found very high concentrations of nitric oxide, interleukin 1B, interleukin 6, and tumor necrosis factor alpha. So in addition to substance P, in addition to phospholipase A2, we now have a more fundamental appreciation for what the inflammatory mediators are, which are responsible for the etiology of cervical discogenic pain. This is a very important concept because when we talk about things like PRP, when we talk about things like stem cells, when we talk about things like prolotherapy in cases of neck pain, we have to understand fundamentally why those modalities could potentially be useful for our patients with discogenic pain. Now, the prevalence I told you from Bogduck and April was about 20% of individuals who had neck pain and head pain were related to more related to the disc degeneration. 20% was due to the facet joints. 40% of individuals had pain from both the facet joint as well as the cervical intervertebral disc, and 20% had pain that was neither from the disc nor the joint itself. So Mangiaconti, many years later, wrote a paper which was a systematic appraisal, 8 studies, 100 manuscripts, and found the same prevalence, about anywhere from 17 to 26% for cervical disc-related pain. Now, this paper was about discography because many of us say, well, shouldn't we be doing discography on all of our patients who we suspect have a discogenic etiology for their pain? And the answer is no, because the level of evidence for cervical discography is level grade 4, which is very low quality of scientific validity and evidence in its favor. However, if you undertake the process of discography, you have many options available to us. We can do fluoroscopy-guided discography. We can do CT scan-guided discography, or we can do ultrasound-guided discography. Here's a nice paper of 60 patients. 30 or half of the patients received ultrasound-guided and CT scan-guided discography versus 30 patients or 50% of the patients who received only CT scan-guided discography, and the results were fairly equivalent. The benefit of ultrasound was that it reduced the requirement of CT scan. So ultrasound reduced the radiation exposure. We know that CT scan imaging is associated with a very high level of radiation exposure. So the patients who underwent both ultrasound as well as CT scan imaging had less radiation exposure. There were 2 hematomas in these patients, in these 60 patients, and in both cases, the hematomas occurred only in the patients who underwent CT scan imaging without the benefit of ultrasound guidance. This shows the ultrasound imaging as well as the CT scan imaging. So you might want to consider using the combination of ultrasound and CT imaging if you're going to undertake discography. Now, we talked about nerves, we talked about the discs, we talked about the nerves to the discs, we talked about chemical mediators of inflammation. Are there changes that occur in the brain on functional MRI studies for patients who have cervical discogenic pain? And the answer is decidedly yes. This is in a recent publication from 2020. Looking at 38 patients, there are dynamic changes in brain functional activities that we find on functional MRI. Where do you find them? You find them in the precentral gyrus. You find the changes on functional MRI in the post-central gyrus. You find them in the thalamus, in the insula, and the anterior cingulate cortex. So where you see the blue and the orange, these are the changes that light up with functional MRI on patients who have cervical discogenic pain. There are real changes. It is a real condition. It's not a condition which doesn't have fundamental scientific validity. Who is at risk for developing cervical discogenic pain? Well, anybody can potentially get it. This is a nice paper which was published 2 years ago about the factors which are associated with chronic cervical discogenic pain. They looked at smokers versus non-smokers, and the smokers were individuals who consumed at least 1 package of cigarettes per day, that's 20 cigarettes. They looked at office workers working at least 30 hours per week. They looked at body mass index, less than 23 and greater than 23. And they looked at other factors, and they found that the 3 factors most associated with cervical discogenic pain were office workers and smokers and individuals who had a body mass index of greater than 23. In fact, the body mass index exponentially increased the chances of cervical discogenic pain. Let's talk about the procedures. Dr. Chang Chen gave us a beautiful rendition of fluoroscopically guided procedures. I'm just going to show in very brief terms about the use of cervical interlaminar epidural steroid injections. I didn't raise my hand when George said, who does transforaminal injections in the neck? I only do them with local anesthetic without any steroid whatsoever. I only do them if a surgeon has a concern about which level might be the offending level before undertaking a surgery of the neck. But there's no scientific validity to putting even a 1/2 cc of local anesthesia over a selective nerve root. That local anesthesia can migrate to several segments. So the concept of a targeted injection of an isolated nerve root is really fundamentally flawed. This is a nice paper from Dr. Manchikanti. Some of you have heard of his name. He's the president and the founder of the American Society of Interventional Pain Physicians, one of the largest pain physician groups in the entire world. He's published about 600 scientific papers. This is one of his papers from a few years back, 11 years ago. He looked at 120 patients. Half the patients received local anesthesia only, and half the patients received a combination of local anesthesia and steroids for cervical discogenic pain. And they found no difference whatsoever in the success rate. The success rate was 73% success for local anesthesia only, and 70% when local anesthesia and steroids were injected. And this was a 2-year study. They followed these patients for 2 years to determine efficacy. That calls into the question, do we really even need steroids for our patients? And you may say, well, that's just one paper, but this was followed up several years later in 2020 by a larger study with 370 patients, same protocol. Half of the patients received local anesthesia alone, and half of the patients received a combination of local anesthetic and steroids. And again, there was no statistical significance whatsoever, whether the patients had steroids added to their cervical injection or they had steroids and local or just the local anesthesia alone. This is a paper that I was privileged to participate in. We published this about 10 years ago. This was looking at whether cervical epidural steroid injections actually have efficacy with cervical discogenic pain. And the answer was yes. So how favorable were they? We looked at all the papers published in the peer-reviewed literature up to that time, and we found that there is level 2, grade 2 scientific evidence in favor of the use of epidural steroids for cervical discogenic pain. That same year, I was privileged to participate in another study of cervical injections, level 2 evidence for the long-term management of disc herniations, again, cervicogenic pain in the neck, so very high levels. And grade 2 evidence, this is the definition if you have any interest in science and the basic foundation. Levels 1, 2, 3, 4, and 5 are defined here. Level 2 is that the evidence is obtained from at least one high-quality randomized controlled trial or multiple relevant, moderate, or low-quality randomized controlled trials. Does the epidural injection in the neck for cervicogenic problems, for cervical discogenic pain, does that translate economically? And the answer is yes. There's the phenomenon known as quality of adjusted life years. So you save a patient medical bills of about $2,500 per year if they respond favorably to your cervical epidural injection for discogenic pain. We created in 2021 our evidence-based guidelines. I was one of the authors for the American Society of Interventional Pain Physicians. Again, showing level 2 evidence. Again, as each year goes by, more studies are published that we are then responsible for looking at and grading. But the grade of evidence in favor of epidural injections for cervicogenic pain remains very high, very strong. Let's look at radiofrequency ablation for cervical discogenic pain. One of the earlier papers, now 7 years old, was a single case report of intradiscal pulsed radiofrequency for managing chronic cervical discogenic pain. The patient had a C4-5 pulsed radiofrequency procedure performed with great success. Here's a nice study of multiple patients, CT scan guided RFA targeting herniated edge of the cervical disc for neck pain. Again, this was for discogenic pain in the neck. 213 patients completed this project, so that's a huge study. And they studied patients at 1 week, at 1 month, at 3 months, all the way up to 1 year. And you can see that the success rate of greater than or equal to 50% improvement was very high in the 80%, and that lasted for up to 1 year. This is the data showing 6 months, but the study was actually completed for an entire year, showing very high levels. More than 80% of patients had a 50% reduction in pain. Let's talk about coblation. Coblation is kind of similar to radiofrequency, but less intense energy, less heat is produced. Here's a very nice paper which was published 10 years ago looking at coblation technology for cervical discogenic pain. They looked at 40 patients. They found high levels of success. Pain relief, again, at 1 week, and then at 1, 3, 6, and 12 months, the pain VAS score was reduced. The proportion of patients who graded the response as excellent was very, very high. This is a single patient, because I showed you data for 1 year. This is a single patient who had 4 years of successful analgesia based upon coblation injection, coblation procedure for a cervical disc at C4, C5. And this is a study of coblation therapy recently published 5 years ago of 18 patients showing an improvement in pain, an improvement in their, starting from post-operative day 1 and extending all the way out for 1 year, and showing that the patients who graded their pain as excellent or good was very, very high. PRP. I read several papers here. There were case reports. I was really placed into a mode of severe humility, and Dr. Chen knows me for 20 years. George knows that I'm not a humble person. I have a YouTube channel. I have 2,600 videos of myself on YouTube. No one could ever make a mistake and consider that I'm a humble person. But I read these beautiful papers by Dr. Lamb. The first one, and I say they're beautiful because the amount of anatomy and the amount of detail that Dr. Lamb and his associates put into this work is phenomenal, something I had never seen before. I'm a lot older than most of you in this room, and I didn't grow up using ultrasound, but this really made me take a step back and think all the things that I really have a knowledge deficit of. So this was the use of PRP, ultrasound-guided cervical intradiscal injection. I love this case report. It was followed up a few years later by another case report where they changed the perspective of going from lateral to using a medial approach, which really makes a lot of sense anatomically, but it only makes sense anatomically if you understand what the risks and the pitfalls are of using ultrasound to gain access to the cervical disc. I like the fact that they changed their approach, their needle pathway, for patients for whom it is impossible to enter the disc using a lateral to medial approach. Then some Americans took the idea a little further. They studied 18 patients using a very similar approach. And I include this study because, unlike the arrogance of many Americans, they actually gave Dr. Lamb credit for his wonderful work, which laid the foundation for this study. In 18 patients, 14 patients had a more than 50% response to platelet-rich plasma injected for cervical discogenic problems. 14 out of 18 responded favorably, and they gave Dr. Lamb his due credit for laying the foundation. There are some of the beautiful images obtained from the ultrasound use in that study conducted over in my part of the world in the United States. So what about the use of other cells? Well, I do a lot of procedures using stem cells. I mentioned that earlier. I use umbilical cord-derived stem cells. And this is a beautiful paper. This was a paper which was derived from 7,623 articles. A total of 80 articles met the inclusion criteria. More than almost 2,000 patients, 1,974 patients were injected, finding high-quality evidence for both PRP injected intradiscally and stem cells. But more importantly, the paper pointed out that stem cells and PRP might be useful not just injected intradiscally, but also injected intraosseously or injected into the epidural space. Just a quick vignette. I've been doing stem cell work for about 6 years now, and I used to inject everybody's discs, and I stopped doing it about 2 years ago. I do not inject the discs with stem cells derived from the umbilicus any longer because the patients typically have a 3 to 4 week response of severe agonizing pain. And we work the patients up. None of the patients have had an infection. None of the patients have had any long-term sequelae. And almost all of the patients have improved, but I just don't have the heart to have to deal with patients complaining for 3 to 4 weeks. I just don't have the stamina for it any longer. So this is actually one of the papers that I published. I published it this year in 2025, based on our work with using multipotent umbilical cord-derived stem cells. It was a study of 48 patients who had epidural injections as well as facet injections, as well as intravenous stem cells with a very high success rate of studying these patients for up to 12 months. You can see the numbers are there. I encourage you to read it if you have an interest in the use of regenerative medicine. Finally, other things which have been used, which are undergoing some investigation now, they're in their infancy. Percutaneous jellified ethanol has been injected for cervical discogenic pain. Ozone therapy and injected intramuscularly for neck pain has been utilized as well. So I'm sorry if I went a minute or two over, but thank you for your patience, and thank you for your patience for the entire day. Cervical discogenic pain has a very high prevalence rate. We know that it's a real phenomenon. There are studies in animals, there are studies in humans of the nerve innervation of all these chemical mediators of inflammation, substance P, nerve growth factor, ADP-derived nerve growth factor. Symptoms are often confused with facet joint pain. You have to have a comprehensive approach to these patients. I don't think you have to inject everyone with discography and with facet joint injections, but you have to have a process of ruling out alternative and competing events before undertaking treatment. Symptoms, treatment often includes cervical epidurals, high level of evidence, level 2, coablation therapy, high level of evidence. PRP and stem cells, the evidence is still accruing, but I'm a firm believer that PRP and stem cells are useful for these patients, and I believe that it's mandatory to use some form of imaging, whether it's CT scan imaging or a combination of ultrasound and CT scan imaging or fluoroscopy. Sorry for going over time, and again, I appreciate your patience today. You've been a wonderful audience. Thank you so much.